Next session is a session by Pfizer. I invite Dr. Akhil Kapoor sir from Banarasi to moderate the session.
I also invite the panelists, Dr. Chandrakant sir, Dr. Satvik, Dr. Tara Chanbos, Dr. Mineet Shah. Mineet? Shailesh sir requesting you to be in the panel as well, if feasible. There was a non-sponsored session before, and so the session which was preceding this, that was Ullas sir session. In that non-sponsored session, that has already been shown and was discussed that Lorlatinib has definitely an edge over multiple other TKIs. So that's not a doubt. I think that makes our job much easier, because when in a non-sponsored discussion, it has already been shown that what is going to be the best possible TKI, it becomes easier for us. Mineet, your comment on this itself. Yeah. Go.
Socially already. So I think it leaves us with a very competent first-line treatment choice. Usually we have doubts and discussions as to this is because of this and the other choice is because of this. But I think it's set the field apart. So with the data both promising in terms of activity, intracranial efficacy and safety, I think it has set the field a little bit apart.
I think with the time which is coming, I think there will be no requirement of panel discussion also for such specific drug for ALK, because we know presently the best possible TKI is this, and there's no doubt about it. If this is not feasible due to cost and other things, then how to go, that needs to be discussed. But other things, I don't think there is a science which is lacking anywhere, and there is a separate discussion required in terms of this. Tarzan, was any different?
I was just searching. ALK G1202R mutation is resistant to Lorlatinib, right?
Yes.
And more sensitive to Crizotinib. So we should look into the mutation pattern also, which is more.
G2308, no?
G1202, just Google.
Okay.
और क्या करता मेरे को पता था that वो उल्लास सर ने कुछ छोड़ा तो था नहीं, तो मैंने वहीं देख लिया just.
So I think the thought process should be, if the patient comes to you, which are the patients which you will not be giving Lorlatinib? You know, that is the question what comes to my mind. The choice is Lorlatinib, but is there anything where you cannot give it? And that usually happens, you know, when the in an oncology institute, it's a different story. But you know, in a community medicine, when you're practicing community oncology, it happens that the patient with brain mets and ALK-positive is already radiated when the patient comes to you. I mean, that is a scenario where you think twice before starting Lorlatinib as a first-line treatment.
So, Chandrakant sir, there is a situation in EGFR. For example, patient was started on immunotherapy outside, and the patient later came positive to be EGFR. So it's the same thing which was we dealing with previously. So we were using to start first-line TKIs and then shifting to osimertinib after 2 to 3 months. Something like that will be applicable here. What do you suggest? Patient has been given brain radiation, and now immediately don't want to start Lorlatinib. Something like that will be applicable.
Right. So there should be a bit of RT wash period, yes. But in a disease like ALK-positive lung cancer, the aim is we do not want on-target mutation to develop. Means I want to inhibit all the domains of ALK. Only with that I will be able to attain the longest PFS. And number two, I do not want the brain to be touched by cancer. These are the two things. Because the moment there is brain met, whatever you do SRS, you do surgery, there is going to be residual problem. And number two, the moment there is progression, whatever next line of therapy you give, you will not be able to salvage it. So the key is to give the best treatment in the front line, because the PFS1 is the one that decides the whole story. and make sure the patient, if there is brain mets, melt it away with the TKI. If there is no brain mets, do not allow the patient to develop metastasis. Because if you start the similar Lorlatinib in the subsequent lines, like third line, second line and beyond, post first or second generation TKI, you would have what is called compound mutations. You will have G1202R, as Dr. Tara was saying. So when you have compound mutations, even then this Lorlatinib may not work. So therefore in oncology, the thing is, if you have the best drug, do not keep in your pocket. Give it to the patient. Give the best PFS one, because that is the one that decides the long-term thing. And make sure the brain is not touched by cancer. I think this holds good for all the cancers, and especially lung cancer.
Yeah. So it's very, very clear that we want to avoid any resistant mutations, especially compound mutations, to which most of the TKIs are not sensitive. So what happens? We are now looking actually towards 4th generation LTK also, because since Lorlatinib is being utilized so much, there are some mutations which are developing, to which most of the TKIs are not sensitive, and we don't have anything left after giving Lorlatinib. So Vineet, do you want to show some focus on 4th generation TKIs, ALK TKIs?
So till the time the data is well enough and it beats the current Lorlatinib standards, I think the standards are set quite high with the 3rd generation TKI. So the 4th generation has to, I think, better intracranial penetrance, and the resistant mechanisms which develop probably should be delayed or impaired. So I think I just want to stress upon what Sir was saying. So we usually don't talk about that cohort of patients who, as Sir was saying, may be Lorlatinib potentially ineligible. So what about patients with familial hypercholesterolemia or hypertriglyceridemia? Or what about patients who are already on mood stabilizers for mood disorders, schizophrenias? So I think more than the RT, where I don't have a clear-cut data to show that why I shouldn't give Lorlatinib, but what about these patients who are predisposed from before?
Correct.
Any
so
change
this
in
is very,
approach?
very important and relevant question which I wanted to come at, and Vineet has already highlighted that point. Apart from radiation, these two are the situations where we are somewhat concerned. Familial hypertriglyceridemia, whether you can give Lorlatinib or not. If you are planning any other LTKI, whether you're losing something or not. So these are the important scenarios. Familial hypertriglyceridemia, I think if it is well under control with the rosuvastatin, we can still give Lorlatinib. And we had a patient, since we were doing genetic testing in a lot of patients, we had some interest in this particular aspect, and SGPGI is doing testing for genetic component of hypertriglyceridemia. The patient had a testing done, and the familial hypertriglyceridemia. The patient was started on Lorlatinib. Thankfully, she is doing well on 40 milligram of rosuvastatin. So rosuvastatin was in higher dose than the routine doses. Another situation which you highlighted, so patient on mood stabilizer, whether we are able to give Lorlatinib or not. This is another scenario. So sir, Kumar sir, we were discussing and highlighting, since we are so much convinced about the Lorlatinib data, now we are there's no point in discussing when to give Lorlatinib. The point is discussion when not to give Lorlatinib. So we changed the panel accordingly, and we were discussing about that. A patient who is on mood stabilizers, sir, are you comfortable in starting Lorlatinib, or would you opt for other TKIs? What is your suggestion, sir?
One patient where it is a troublesome, having mood disorders, but far uncommon. Then you will have few things. There is some episodes will be there, but where I had to really get troubled and stop, it does happen. So if the patient is already on mood stabilizer, then to start this situation I have not faced. So this is important. If someone is on mood stabilizer, but when that happens, it is really disturbing, because by the time patient starts responding, patient is good, and inherently you feel somehow you want to continue the treatment. After that, giving mood stabilizer, that also have not done. That patient, we stopped it and we changed the treatment, if I remember correctly. But yes, I agree with you. This is one drug which you will like somehow to give it. You will say, if you're starting it, somehow you will try to manage side effects and see that patient continues the treatment. Anyone, your or anyone else experience?
Anybody had in faced such situation? We have faced some such situation already. Patient on mood stabilizer on
Correct.
3 drugs from the psychiatry department of BHU, and then patient was affordable for any and every treatment. Patient had taken opinion from MSKCC as well. The
Okay.
patient came for opinion since patient had seen multiple publications on ALK from me and Kumar sir. So patient asked met me, and patient asked whether you want to discuss with sir also. So I had a small discussion with sir as well. So this patient we didn't opt to start on Lorlatinib. This is the only situation I think is where we are not very comfortable in starting Lorlatinib.
Yeah, we may end up in future, once we are more comfortable, we may end up, but
So we had a 30-year-old lady whose presentation was altered behavior.
Okay.
So MRI, CT done, there is nothing. And then ATT taken, there is no response. And then someone did an MRI and there is a meningeal uptake. And they did a cell block and liquid, and it came as ALK in that. So for that, patient was set on Lorla. So patient is in CR now almost 3.5 years. So, I mean, just a leptomeningeal disease can also be an ALK present, and here and there lymph nodes.
Okay.
And they were sort of reactive reported. So that's such rare presentations. So make sure you're not treating a brain problem due to ALK when you're, and the reason why there is bit of psychological disturbance due to Lola is a bit of NTRK pathway inhibition. That is a probable reason why you have this psychological disturbances. So bit of NTRK pathway is also a little bit inhibited by Lorlatinib.
So the good thing about Lorlatinib is that it is penetrating brain so much that there is less chances of developing further brain metastasis, and disease control in the brain is much important. But if we get to have access to 4th generation drug which is going to be developed, is under development, again we'll be very much concerned whether it is having much higher neurological toxicity. So we all want to see higher generation drugs, but whether that will solve the problem or not, because we don't want to reduce further quality of life as well. If there is higher neurological toxicity, I think most of us will not be agreeing to utilizing first line drug which has higher neurological toxicity than Lorlatinib. With Lorlatinib, we have now become comfortable because we have now some experience. Thankfully, we started to have in second line. A lot of patients had compassionate access drug, which the data was published by Amit, and we had discussed this yesterday as well. And this is the area we want to understand. Again, the problem is that 20% patients will develop brain metastasis despite CNS penetrating second line drugs. So this was the usual paradigm. We started with Crizotinib. Crizotinib is mostly out when it is not being utilized through access program. But if the patient is affordable, cost of Crizo and Crizotinib are nearly similar. Most of the time we start with Crizotinib if the 3rd generation is not feasible. And then what we see, 20% patients of Crizotinib are developing significant progression in the brain. That is causing a significant percentage of the patients to drop out. So 25% of ALK positive patients do not receive available next line therapy. That's the most important problem. And we have seen this in our own data set, which was published in JTU actually. The 441 patients data set of ALK positive, which was published from Tata Memorial, clearly showed that a significant proportion of the patients cannot receive second LTKI also, though it has been discussed in multiple other symposiums that ALK is a forgiving disease, you can use next generation, but what I feel is that always if the patient progresses in the brain, the problem is that the patient's quality of life will be so much deteriorated that you will think whether you should treat or should call the day off. Tarachan, do you agree with the same?
Yeah.
Completely agree.
Because the brain mets usually make the life.
Yeah. So all these data sets are already clear. The response rates, crown data, that already we have 5 years data becoming available. So we want to just come to the very rapid discussions. At 60 months median follow-up, median PFS was still not reached with Lorlatinib, and this was just 8% with Crizotinib. So this is about the PFS. Mineet, I would request you to highlight the situations of concomitant mutations. Again, this is very relevant in EGFR, has been discussed multiple times. In which scenarios of concomitant mutations and the variants of ALK you'd be thinking that these patients are going to have poor prognosis and poorer outcomes?
The crown data was really excellent, but the only scenarios which where the crown data reached the median one was the variant 3. So we all know that variant 1, 2 and 3 does have a prognostic impact, and variant 3 was the one where it actually reached the median of 53 months. Another very troublesome scenario is TP53, but it's important to know that all TP53 mutations are not the same. It's important to know whether it's in the DNA binding domain, not in the DNA binding domain. So just the mere presence and VAF of TP53 is not important. It's important to talk with the MTB team and the molecular oncologists and see how much of an impact it has. The data is there of TP53, but a number of other concomitant mutations also have an impact, as we have seen in EGFR. There is CTNNB1, we have SMAD4, we have so I was talking about MTAP, and also all of these concomitant mutations do play an impact, and we should have two as a bifurcation: presence or absence of TP53, or presence or absence of any concomitant mutation. And we'll see that that cohort also does make an impact. So yes, sir, that's about TP53.
Satvik, I would wanted your comment on the variant. Do you think having knowledge of variant will be useful when you are utilizing the treatment in ALK?
So now, if we are now giving Lorlatinib upfront to most of the patients, so I don't think earlier when we were using, then the variants were more useful.
Okay. And if a patient is borderline, patient is doubtful whether I should start with Lorlatinib or some other TKI due to cost constraint, in which variant you will be more pro towards utilizing Lorlatinib?
So I think 3 is well known. That is the variant.
Because variant 3 is known to have poor prognosis. And with variant 3, the median PFS with Crizotinib comes down to just 6 months or even less. So that is the most important, that patients who are even on drugs like Alectinib, and some patients you see they are progressing within 4 or 6 months of starting treatment. Most likely these were variant 3 which were not previously tested properly, or this detail was not available. Because most of the time labs report as a ALK fusion, and we don't ask for the type of variant. But thankfully in the academic centers like TMH, we are now clearly reporting the variants as well. I think that was Chandrakant sir. This is useful information for prognosticating and some choice in the TKI as well.
Very important. So one of the first experiences of Lorla for me was Crizotinib, 3 months progression, ALK positive by IHC and negative by FISH. And then we gave PEM carbo PEM maintenance for 1 year and then progression. And then we did a rebiopsy and sent for a comprehensive genomic profile. There, IHC was positive, FISH, NGS variant 3 mutation. Okay. And now it's almost 3.5 years, Lorla progressed. So that is how it is important. So variant 3 at times, IHC may be positive, but your conventional FISH may not pick it up. So we need to be careful before we decide on this. So variant 3 is important.
So that's the importance of getting a good quality NGS at the baseline itself. People ask, you are 50%, when I quote the data that 45% patients or TMH for NC are EGFR positive, what is the need of doing NGS? I think this was a very relevant question which a patient actually asked me. I told the patient, आपके NGS में EGFR exon 21 आया है, और EGFR मोस्ट कॉमन म्यूटेशन है, अच्छी बात है कि हमारे 100 पेशेंट्स में 45 का EGFR पॉजिटिव आता है. तो पेशेंट ने पूछा फिर NGS क्यों कराया? उसने पढ़ा हुआ था कि RT-PCR होता है, वो थोड़ा सा फास्टर रिपोर्ट भी आता है. The patient asked, this is the importance which is difficult to communicate to the patient, but yes, we need to know about concomitant mutations. We need to know about various other prognostic factors. If the NGS is being done at the same time, we know that we can get knowledge of various other things at the same time, which we discuss about STK, KEAP1 if the driver mutation is negative. So this is the importance of having a good quality NGS at the baseline. This is a one-time investment, but very useful for the patient. So don't back out of it, even if your 50% patients are EGFR or ALK positive. So this is the intracranial progression data. I think this is very, very relevant. Shailesh sir, I request you to highlight this data and how much is this of relevance.
So I think I can't see the HR, but HR is 0 point. So you know,
0.06.
so that's what I'm saying. I'm not able to see the HR. so that is the data. I mean, hardly anybody is going to get progressed in the brain. And see, one of my friend actually had a ALK positive lung cancer, and he progressed in 2 years. So the issue was like what Dr. Ullas Batra said, you know, 30% of the patients are anyway going to progress in 2 years. But also important is to know the compliance, because when I really went into deep into it, the compliance was not there. So I mean, like you always blame that the disease has progressed, but also important to know the compliance of the drug.
So compliance tends to be poor in TKI, probably mostly due to cost issues. So that is very important that we are counseling the patient about the TKI. We should ask them to continue at the proper doses at advice. If it is requiring dose reduction due to toxicity, it is fine. There is already data. If you are reducing due to toxicity, it is fine. But whether the dose reduction is like, for example, patients start taking the alternate day to reduce the cost, whether that is as effective as not, we don't know. There are some studies which will be upcoming for that also, but that is very, very relevant question, and we'll see it later.
Akhil, sometimes re-challenge is also quite effective. Because one patient of mine was on Lorlatinib for 6 months. Patient was responding. He was getting from ESI, but he was still out of pocket. So he went. I wrote for the 2 months of the Lorlatinib. He took only 1 month and then went for some laddu, Baba's laddu, and came for 2 months after that. Sir, please check my CT scan. Yes, it is now controlled still. Well, I have left the Lorlatinib and I am taking laddu. And after 2 months again came, and then the disease was progressed. So he asked me to write it again, but it is not possible to write in ESI again, because if the disease has progressed. Then I asked, do you have medicine? So he told me that is having medicine for 1 month, and he took that. And after that, patient was again responding, and I restarted, and now patient is coming till now, and he was the first of my patients of Lorlatinib. Now 4 years are going on.
So that's when the patient is non-compliant or has stopped treatment, then most of the time re-challenge helps. That is a very important point which has been brought about. Dr. Satvik, I would request again your comment regarding a situation. Patient, sometimes we used to think Lorlatinib will be best if the patient has baseline brain metastasis. When the patient doesn't have baseline brain metastasis, still is it useful, or you can go away with the second generation TKIs?
No, even without brain metastasis, if we see the results, Lorlatinib is still useful, and it should be the first priority, irrespective of.
Patients will progress in
Obviously,
the brain,
they will
making
progress
it
again.
more difficult. So, message for the students specifically: patients with or without brain metastasis, Lorlatinib remains the drug of choice with the available data, because it is relevant in both the settings, irrespective of presence of brainland brain. And if we see the intracranial response rates, this is very relevant because we were discussing about the stereotactic radiation, we were discussing about other modalities of the radiation, and the patient is asymptomatic without much edema. Chandrakant sir, what is your comment, and how do you first counsel your radiation oncologist, then counsel your patient?
So I personally believe if someone is going to live for 3, 4 years, 5 years, radiation should be avoided in all situations. So if a patient is not grossly symptomatic, even with mild edema, you start the patient on Lola and do an imaging after 1 month and make sure that it is not progressing. So these patients are going to live long, and WBRT is a big no when you are giving Lorlatinib, unless it's a very gross disease. The moment you give radiation, there are toxicities. He will keep on needing DEXA, and he's going to live long, that is for sure.
So radiation oncologist sometimes tells us that we will not giving WBRT, we will giving SBRT only. What is
even if SBRT, there is going to be some neurodeficit, whatever.
Any experience of having some?
So actually, in our MDT now, the unanimous decision is to for delayed RT, whether it's SRS, SBRT or WBRT, because now the concept of driver mutant positive and a good brain penetration with the TKI is well accepted in the MDT. So we all, even our radiation oncologists, are primed that if it's EGFR or ALK, and if we are able to deliver the TKI, then we'll delay the RT, as long as the patient is not symptomatic.
So what's your concern with SRS?
So no absolute concern. The only thing is, we all know that WBRT, the side effects start developing at the end of 1.5 to 2 years. The side effects start developing in terms of cognitive decline. We don't know when it will start for SRS. So although SRS is highly specific, as what Dr. Chandrakant was saying, maybe we'll see at 5 years or 6 years some necrosis, long-term necrosis
so
area.
Actually, radiation necrosis is very, very troublesome. When it develops, it will not develop in all patients. It will develop 1 in 10 patients who have received SRS, but that will make you suffer so much that the patients will have a tough time managing radiation necrosis. We have utilized low-dose bevacizumab for radiation necrosis with ALK, with Lorlatinib ongoing. Some patients had some benefit for radiation necrosis, but it's a difficult challenge that disease is well controlled, but patient is suffering because of the radiation necrosis. So that is why we are very concerned. So this is a very important message to our budding medical oncologist, that have a discussion with your colleagues. When you are discussing it, and ask your radiation colleagues what are the expected toxicities. Your radiation oncology colleagues and other colleagues should be able to tell the toxicities and whether it is going to hamper the quality of life of the patients, and whether that treatment will actually be helpful or not in the long term. If you are using drugs like Lorlatinib, it becomes less useful to have giving SBRT in such settings. But if a patient is not able to be started on Lorlatinib, most of the patients are able to receive Crizotinib due to support program, then it is fine to utilize radiation, correct? So this is the subgroup analysis. Poor prognostic biomarkers we have discussed, variant 3A, 3B. A good point is that with P53, again I will request Shailesh sir to highlight the P53 mutant outcomes with Lorlatinib.
I think the outcome with P53 is, we all know that it's a poor marker, it's a poor prognostic marker. So presence of TP53 is going to have a poor prognosis.
So good point is that even with P53 mutation, Manit had highlighted a useful point. Many P53 mutations are different. We are usually collating all P53 into one subgroup, but that is not correct. Some P53 mutations are not so bad, but most are bad. And P53 mutant, the expected PFS with alectinib is 18 months. And that is the subgroup analysis. And with P53 mutation, the Lorlatinib PFS is 51 months. So that's no comparison, and there is no doubt in poor prognostic subgroups you are utilizing Lorlatinib, and we always check. That is why P53 co-mutation, which is a very, very important aspect, and we strive to give Lorlatinib by some or other mechanisms if the patient has P53 co-mutation. So coming to the safety and efficacy, we had very initial discussion, because safety is the only concern actually, because everybody is convinced about efficacy. The safety was the main concern, but now I think with the available experience and everything, we are becoming much and more comfortable about the safety part of this. As it was being discussed by Ullas sir in his previous panel, the patient has some difficulties, disturbances. First, you should have detailed counseling to the family members, close family members. If a spouse is looking together, the spouse will be the first person who will notice some changes, because patient himself or herself will not be able to note that, because these are subtle changes, and these will be noticed first by spouse. And what we have written in our counseling brochure, that stop for some time and report to the hospital either by mail or come to the hospital. That is what we do, consult to our patients. And when we see that within 48 hours to 3 days, that is 2 to 3 days, the effect again starts to wane off, then mood disturbances tend to come off. And in this situation, we can just reduce one step down, and most of the time this will be good. And the most important part is that these toxicities will develop much and much more in younger patients. That is important, because
So do you, in your the sheet that you attach for patient counseling, do you consider doing MMSE at baseline for these Lorlatinib patients?
It is advisable. It is advisable, as Vineet was trying to highlight, because these are subtle changes, and the patient is already suffering from a diagnosis of cancer. So the changes, mood changes, are due to the drug or due to some psychological disturbance due to diagnosis of cancer per se. That is very important, because we have seen patient on Crizotinib also having mood disturbances, but that is not due to Crizotinib. That is because of the diagnosis of the cancer. So that is an important concern, and this is a very valid suggestion. We should have a baseline MMSE if feasible, so that you have a ready reckoner to compare when the patient has some of this disturbance. So that's a very valid comment. So Sir, any comment on this baseline MMSE?
Totally agree. You need to be knowing whether the patient has baseline issue or whether it is developing over a period of time. That is an objective way of assessing it.
And rest other toxicities of Lorlatinib are mostly paper toxicities, which we have discussed and covered multiple times. Rosuvastatin and fenofibrate are very commonly utilized. Atorvastatin is a no-no because of interaction with Lorlatinib, so that is an important message. atorvastatin is to be avoided when you are treating lorlatinib-induced hypertriglyceridemia, but rosuvastatin is the preferred one. You can start with 10 mg and escalate up to 20 mg. Most patients will do well with 20 mg. And any comments?
So my patient asked, after 6 months, my cholesterol is so high, will I die of heart disease? So there is data that the cardiovascular mortality is not much, even if there is cholesterol.
Yeah.
So it's fine. It's not that bad cholesterol.
And the point is that if there is uncontrolled cholesterol, the effects start to develop in heart and vessels after 15 to 20 years. We are yet to see so longer follow-up. So what will happen after 15 to 20 years? If the patients are able to survive to that duration, then it will come into mechanism. And then
somebody who already has, I think, dyslipidemia there.
if you are not able to control it, then it becomes an issue. But if you are able to utilize rosuvastatin and Crizotinib, then most of the time it is well under control. So that is why it is called paper toxicity. Another problem, fatigue and edema. Tarachan, was any comment on edema management with lorlatinib or other MET inhibitors also? Both have similar side effects.
What am I doing in my OPDs? Usually whenever even any patient of any disease is coming, we are checking weight. That is the practice from
Weight
TMH
every
OPDs.
time. Okay.
We are taking weight of every patient, and that's why we are monitoring the lorlatinib patients also. And if there is a weight gain or there is a pedal edema, we are adding like a lacilactone half tablet OD in the morning only,
Okay.
and that is more than
Most of the
sufficient
time
to control the
And
edema
some
and weight.
physiotherapy will also help. So utilizing drug, utilizing some life-changing parameters, and then utilizing lacilactone is very useful. So let's come to one of the cases, because we have covered all the toxicity part. This is one of the real cases treated at TMH Varanasi. 64-year lady, shortness of breath at 3 months, PS2 at the baseline, PET CT showing a large mass, right lung mass, adenocarcinoma, PDL126, NGS was awaited. NGS later came as to variant 2, which is a rare variant actually, and that was E20A20 fusion. And this patient was started on lorlatinib, and you can see the responses, and these are the further responses at 6 months. This patient is on 100 milligram lorlatinib and remains in near CR from nearly 4 years of therapy. So this was one of the initial patient which was started on lorlatinib when I moved to Varanasi after Mumbai, and the patient has on hyperlipidemia is there, but rosuvastatin 10 mg is being utilized and patient is doing well. So it's very clear, there's no doubt about that. Lorlatinib is the standard of care treatment, and it remains the standard of care. There are some pros and cons which needs to be identified and covered and discussed with the patient, and you need to manage, you need to learn how to manage the toxicity. You don't need to blame the drug toxicity. It is, onus is on us to manage the toxicity well and discuss with the colleagues who are having higher experience of managing the toxicity, so that the patient can get the benefit of the best possible treatment. With this, I would like to end here. Thank you for the patience.